Do you know that the facial pain is often misdiagnosed due to the overlapping clinical presentations? Today's case highlights the diagnostic challenge when distinguishing trigeminal neuralgia from salivary gland pathologies. A 45-year-old male was referred from the ENT clinic to rule out any dental pathology associated with the persistent facial pain and swelling since 2 months. Patient reported episodes of intermittent pain in the preauricular region, and this pain was managed by analgesics previously. So on examination, there was mild erythema over the left stanson duct, and there was no frank salivary secretion. On palpation of the left parotid gland, yellowish purulent discharge was seen coming out of the stanson duct, and it was followed by a clear serous fluid. Also on palpation, there was no lith-like consistency detected. So we conducted ultrasonography which revealed parotitis of left parotid gland, and there was a mild glandular enlargement associated with it, and vascularity was increased in that region. Plus there was no lith detected in the sonography. The intraoral periapical radiography of first and second maxillary molars showed mild to moderate periodontitis in this region. So based on the ultrasonography, we gave the initial diagnosis of bacterial parotitis of the left parotid gland, and we started antibiotic coverage which included amoxicillin plus clavulanic acid 625 mg. We also added metronidazole for anaerobic coverage, and we adjusted this treatment for 7 to 15 days depending upon the response of the patient. And to enhance the salivary secretion and prevent the stasis, we recommended to keep the hydration game strong, at least 3 liters of water per day. And for the salivary secretion, we recommended linseed drops for a good secretion. And also we prescribed him the gentle massage of the parotid gland and warm compresses over the involved region. And for the pain management, we prescribed non-steroidal anti-inflammatory drugs. And for the periodontitis in the premolar and the molar region, we did a thorough prophylaxis in that region. So after 10 days on follow-up, patient's salivary function was back to normal. We repeated the ultrasonography which revealed normal bilateral parotid gland, no lith form, the vascularity was normal, and the secretion was good. However, there was no relief in the pain. Now the pain was episodic sharp shooting in the malar region, and it used to provocate on the slightest of the touch. The pain was generally, the episode was generally of 1 to 2 minutes, and this were the classical signs of trigeminal neuralgia. So to confirm our diagnosis, we conducted an MRI scan, and it revealed a vascular loop in the close proximity of the left trigeminal nerve, suggestive of neurovascular compression, which helped us to give the final diagnosis of trigeminal neuralgia. So we started with the treatment. We gave patient carbamazepine 200 mg BD for 15 days. We educated the patient on avoidance of a trigger zone. Also, we gave a neurosurgical consultation for further surgical management if required. So after 15 days of medication, patient reported us with a reduction in the pain of around 60 to 70%. So we decided to continue the same regime for another 2 weeks. So what do you think? Why was trigeminal neuralgia misdiagnosed? Well, what I think is there was a difficulty in localization of the pain in the particular region due to the pre-existing parotitis. And second, the early sign of trigeminal neuralgias are not so typical. And third reason could be the inflammatory sign of parotitis masks the trigeminal neuralgia presentation. So the key learning point in this case is that the trigeminal neuralgia can be masked by various pathologies like salivary gland pathologies or other odontogenic infections. And in case where there is a persistent chronic facial pain which is not diagnosed, in such cases we should always consider a MRI scan. And when managing these cases, carbamazepine is always the first line of the drug. And in cases of refractory cases, you can also go for gabapentin or oxcarbazepine. And regular follow-up is needed in such cases because trigeminal neuralgia might take a longer duration to get better. So this case highlights the importance of comprehensive differential diagnosis when evaluating chronic facial pain. The overlap between the dental, neurological and salivary condition can lead to delay in the proper diagnosis, reinforcing the need for a multidisciplinary approach in cases of chronic facial pain. Clinicians and students never ignore the chronic persistent facial pain. Early diagnosis of trigeminal neuralgia will prevent years of mismanagement and difficulty. Stay sharp, stay updated, and follow me on Case Reports by Dr. Neha.